Good evening, ladies and gentlemen. May you please rise for the academic procession.
Good evening, ladies and gentlemen. Please be seated. Professor Loretta Ferris, Vice Principal Academic, members of the University of Pretoria Executive, including the Deans, VIP delegates visiting UP, Professor Lekan Ayo-Yusuf, Dr. Amade Ayo-Yusuf and family, members of the Faculty of Health Sciences Executive, including our Deputy Deans and other school chairs, colleagues, students, distinguished guests, everyone joining us virtually and online. Good evening, ladies and gentlemen, and thank you for joining us this evening. I am Professor Tiaan de Jager, Dean of the Faculty of Health Sciences at the University of Pretoria. This evening's inaugural address will be presented by Professor Lekan Ayo-Yusuf and will focus on turning the tide on tobacco and industry's product innovation gambit. Please allow me to welcome Professor Loretta Ferris, our Vice Principal, to introduce Professor Lekan Ayo-Yusuf. Professor Ferris serves as Vice Principal Academic at the University of Pretoria, where she is responsible for shaping and overseeing the academic strategy and operations across all 9 faculties, as well as the prestigious Gordon Institute of Business Science, GIBS. She is a highly respected scholar in the field of environmental law, dedicated to advancing environmental justice, both in her academic work and beyond. In addition to her academic leadership, Professor Ferris is the director of the newly established Center for Environmental Justice in Africa, a pioneering initiative focused on addressing critical environmental challenges across the African continent. Professor Loretta Ferris.
Thank you, Professor de Jager. I think we need to lower it just a little bit. It's always that challenge when you speak after Professor de Jager. On behalf of the Senate of the University of Pretoria, it is my privilege to welcome you here this evening to the inaugural lecture of Professor Lekan Ayo-Yusuf. Before we begin, I would like to acknowledge the presence of the Dean of the Faculty of Health Sciences, Professor de Jager, his deputy deans, all heads of departments and schools of the faculty, as well as other deans of our other faculties. I've seen some of them here this evening, other heads of departments, all members of Senate, all staff and students, And then, of course, I want to particularly acknowledge and welcome Professor Ayo-Yusuf's family, his wife, Dr. Imade Ayo-Yusuf, his two sons, Kulade Ayo-Yusuf and Laule Ayo-Yusuf, as well as his brother, Mr. Deyi Ayo-Yusuf, who've traveled from the UK to be here, as well as his other family members who are joining online. I would also like to extend a special word of welcome to some of our special guests here this evening. Mr. Dlomo, who's the chairperson of the South African Parliamentary Committee on Health and the former Deputy Minister of Health. Ms. Hunter, who is the Deputy Director General, Primary Healthcare and Hospital Management of the National Department of Health. Dr. Masuku, who's the chairperson of the Community Safety Portfolio Committee in the Gauteng Provincial Legislature and former MEC of Health of Gauteng. And then Dr. Maseke, who's the Registrar of the Health Professionals Council of South Africa and the former MEC of Health of the Northwest Province. All of our guests here this evening, ladies and gentlemen, please feel very welcome this evening. We are really delighted that you can share this special occasion with us. Because here at the University of Pretoria, we take pride in our highly rated Faculty of Health Sciences, which offers accredited degree programs both at the undergrad and postgraduate level, all of which are recognized by national and professional bodies. Through their excellence in research and in teaching, as well as their global standing, our Faculty of Health Sciences contributes valuable knowledge to the respective disciplines that are represented within the faculty. Currently, the School of Health Systems and Public Health, from where our keynote speaker and inaugural lecturer this evening resides, is one of the leading departments in the South African higher education landscape. The academic quality of our staff, of people such as Professor Ayo-Yusuf, allows us to provide future health professionals with comprehensive exposure to the full scope of this discipline. This extensive training is vital in preparing our graduates for the public health sector, not just in South Africa, but across the continent. Now, when senior academics are promoted to full professorships, or when they join us as a professor here at the University of Pretoria, they are required to deliver an inaugural lecture. And this event is a significant moment in the career of any professor. And each inaugural lecture serves several important purposes. It showcases the research that we do here at the University of Pretoria. It also celebrates excellence in academia. And then, of course, it provides an opportunity for our researchers and our scholars, such as Professor Lekan Ayo-Yusuf, to share their research findings with an audience that includes not just their peers, but also special invited guests, the public, and their family. And this is part of the indelible culture and heritage of the University of Pretoria as an institute of higher learning. Now, let me tell you a little bit more about Professor Ayo-Yusuf. He is currently a professor and the head of School of Health Systems and Public Health here with us at the University of Pretoria. Previously, he served as Dean and Deputy Vice Chancellor for Research and Innovation, both at the Sefako Mogato Health Sciences University. Professor Ayo-Yusuf is an NRF B-rated scientist whose research focuses on behavioral epidemiology and policy evaluation for the prevention of non-communicable diseases. He has authored over 130 peer-reviewed publications. Additionally, he is a member of several editorial boards for international journals and national and international scientific groups. His notable roles include being a member of the Lancet Commission on Oral Health, a member of the World Health Organization Tobacco Regulation Scientific Group, the chair of the Standing Committee on Health of the Academy of Science of South Africa, and a member of the Gauteng Provincial Health Research Committee. Professor Ayo-Yusuf is also the director and board member of the National Council Against Smoking. But he doesn't just work. I asked him what are his hobbies, and he said he enjoys listening to jazz music. So do I, Prof. He also watches soccer. I don't, but I'm forced to because I have 2 boys in my life that does. And occasionally does horse riding. And there I'm also not going to join you, Prof, because I do believe that the distance between a horse and the ground is quite vast. But we are here this evening to listen to his inaugural lecture. And I'm now going to invite Professor Ayo-Yusuf to join us here on the podium to deliver his address titled, Turning the Tide on Tobacco and Industry's Product Innovation Gambit. Professor.
Thank you. It is, wow. Am I nervous? As you can imagine, I've done this a million times, but never in front of my friends, not in front of my classmates, not in front of my sons of family. So it's a very different lecture. Good evening, esteemed colleagues, students, friends, family, and distinguished guests. All protocols observed, as we always say. It is both an honor and a privilege to stand before you today to deliver this inaugural lecture. Long overdue, I must say. But it is still important to do this. As you all know, it is also coinciding with the 20 years since the first and only public health treaty by the WHO that came into existence on this day, 27th of February, 2005. But delivering this address is also important for any professor in the academic journey. This is because the moment like this is not just a personal milestone reflection, but a testament to the collective efforts of mentors, collaborators, and institutions that have shaped my journey. Despite the delay, this is even more special to me that I'm sharing this research journey and our collective efforts to address one of the most pressing public health challenges of our time, tobacco use and its commercial determinants. By the way, delays in events that turns out to be special or unusual outcomes of personal growth is not new to me. As you see a timeline, whether you believe it or not, that's me in that top left picture. It's supposed to be my 10th birthday, but I was celebrating it with my sister, who was having her 10th birthday, 18 months later. So I guess my parents could not afford to have two 10 birthdays in the short term apart. But this delay taught me the importance of family, and I grew up in a very close family, even though we're such a large family, as you can see also from that picture. Well, I decided to keep a smaller family, just 2 of us and my wife, as you see there. That's back in Limpopo, where I started my journey. Well, it also seemed an unfortunate time when I was 11. My parents could no longer have another person in private high school. So I had to attend the first set of public high schools built then by the first democratic government in 1979, who decided to make education free in 1980. The building of the new schools had to be rushed and completed within a year of when the announcement came. So they're typically half-walled, So the problem is always when it rains, so I know what it is when you're in a class when it's raining. However, as you can see, some of that part still remain apart. I did find my classmates. When somebody posted that this is the state of schools in Lagos in 2017, and I couldn't believe it. It was a good time to reflect that was where I came from. However, I got great education and discipline in this school. And I'm sure Timmy, my classmate right in front of me, can testify. Thanks for coming through all the way from the UK. I know some of you are perhaps surprised because I've been told many times that I went to school in Harvard, I was born in Harvard, I did everything in Harvard. No, it wasn't that easy. Well, I moved to South Africa for postgraduate studies in I eventually got admission to the School of Dentistry, not after 2 attempts. The University of Benin, one of the best dental schools in Nigeria. I moved to South Africa in 1995, studying part-time, completed a master's degree at the University of Pretoria in dentistry. One of the best, actually the best dental school in Africa. You can check it out. Fact check. After my appointment, I'm spending quite a long time to talk about myself because I never do. After my appointment as the first Black African and the first dentist to head a hospital in Nelstrom, in Limpopo, with the mandate to merge 2 sites, that was my first job in 1998. One site was for whites only, and the other site was for blacks only. For some of you that know Nelstrom Hospital, you remember Pagame and the one in town. With the support of my then boss, Dr. Jabu Dilamini, which couldn't make it today, but our daughter is here, Mabato is here. Thank you. She believed in me that time, and I'll never forget that. But then I decided to move into public health and completed my master's at University of Pretoria, my second master's at University of Pretoria, and thanks to Professor Eric Book, who was my supervisor for my MPH. Thanks, Eric, for your patience. And of course, honestly, this was also not without a delay. I couldn't understand when I was told I could not do a master's degree, and I had to do a postgraduate diploma, a second one again, in public health. After all, I just completed a master's with distinction in dentistry. I was the head of hospital in Limpopo, but I was not qualified to do master's MPH. But again, another lesson of resilience. Thereafter, I gained admission to PhD at Maastricht University, fully funded tuition, courtesy of Professor Bart van der Borne, my late supervisor who passed away just 3 weeks ago. May his soul rest in peace. I would like to seize this opportunity to also recognize support of my co-supervisor, Professor Priscilla Reddy, who dedicated most of our career to capacity building of historically disadvantaged groups in South Africa those many years ago. Professor Bart taught me what it means to be selfless. He not only organized funding to pay for my travels and accommodation when I went to Maastricht, but he also arranged for funding to fly my wife and my head of department to witness my graduation in Maastricht. This inaugural is indeed dedicated to Bart. I have always acknowledged an important mentor, Professor Greg Connolly, who also primarily trained as a dentist and turned out to become one of the most successful public health practitioners in the US. He supported my application for UICC postdoc fellowship grant that got me to spend my 1 year of training at Harvard School of Public Health. I learned all that I know now in what it is to use science to support regulation, because that year was when the FDA took control of tobacco regulation back in 2008. Now, let's get to some of what has been happening. I'm going to try, it's very difficult to do, talking to my family and friends, but I'm going to try. I remember this particular patient. First of all, I need to say I'm a dentist. My journey started in the mouth. Yes, in the mouth. The very early days, literally, you were only taught as a dentist to restore smiles. And you can see I didn't forget about that, even though you can see the title of that's my thesis in Maastricht. You were taught to restore smile, relieve pains, promote oral health. But in my early years of practice in Limpopo, I encountered a steady stream of patients suffering from severe periodontal disease, oral cancer, and other tobacco-related conditions, only to find out during my first research that my pediatric specialist owned a tobacco farm right around the hospital. Maletsema is here. You remember Dr. Farrand? Where's Maletsema? Yeah. Those were the first set of community service doctors those years. Then I remember this particular patient that changed everything in my life. Let's call her Masakani. Masakani was in her early 60s, a long-term snuff user, and developed a white lesion between her lips and her gums with associated bleeding gums. Her daughter claimed this had been dismissed by her mother and dentist as just a sore. But when she came to me, I took a biopsy. Eventually, the biopsy results came back, confirming this was squamous cell carcinoma. The time I took the biopsy was the top, and this was 6 weeks later after I sent her to UP, and the pathologist sent me the picture of what he saw 6 weeks later. The prognosis was grim, and she eventually passed away within 6 months because the lesions grew so rapidly that she could not be operated. That moment changed my perspective. Tobacco is not just an habit, but was a public health crisis. That was when I also met the National Council Against Smoking, Yusuf Saluji. And I asked, why is it that nobody was doing anything about this? We only talked about smoking. Well, this case and many others pushed me to look beyond the dental chair. I started asking bigger questions. Why are we treating these cases reactively instead of preventing them? What policies could reduce tobacco use and ultimately the burden of disease? Because people like Masakani were only lost in statistics in Limpopo. This informed my early papers. The fact that I was particularly fascinated by the cultural linkage to snuff, of snuff use. And therefore, I was interested, my first paper, or my early papers, was actually looking at traditional healers' perception of smokeless tobacco and health. I started understanding what research was about, because I remember one of the traditional healers we had to visit had to consult before we could get in, and unfortunately the God said we couldn't get in. So I had to travel back. I really wanted to see what was happening, but I missed it on that day. But I did eventually see one of them. The finding of that was that recreational use of snuff was not supported by these traditional practitioners. And it is said that it can only use if one's ancestor used it and have recommended use to cure a particular problem or ailment. And then took another leap of faith, looking at the 1998 Demographic Health Survey on possible link between nasal snuff and chronic bronchitis. And to our surprise, we found snuff users had higher odds of presenting with clinical symptoms of chronic bronchitis, possibly related to the nasal use and destruction of the first line of defense to the lungs. By the way, more recently, studies from the UCT Lung Institute confirmed that nicotine can reduce the ability of immune cells in the lungs to fight infections like TB. Tobacco use in any form is indeed a risk for chronic diseases that affect individuals, family, and communities at large. It is responsible for 8 million deaths annually around the globe, and over 30,000 annual deaths in South Africa, having dropped from about 45,000 annually. I know you may not be able to see the print, but that estimate of deaths was a collaboration between our group and SAMRC, because they required the data that I've been collecting over several years to be able to predict the number of deaths. And this paper was published early last year. It is important to also note that smoking costs South Africa 42 billion rand annually, which is higher than the excise tax of about 13 billion, or profit tax of about 29% of profit that the government might receive. By the way, tobacco industries usually do not declare large profit within South African environment, because most of this is said to be loyalty paid to London and the stock exchange. As you can see from the review of the tobacco research conducted in South Africa in the last 50 years, our research output at the last 20 years at UP, when added to those while I was at SMU and UL, would be the highest after MRC that has been in existence for that long period. Throughout the journey of my research, early days, I've already encountered the industry's gambit. A gambit is a strategic sacrifice, like in chess, designed to gain a greater advantage. In the case of tobacco, the industry's gambit involves inducing or introducing so-called innovative products while masking their true commercial interest and undermining public health. This gambit or manipulation has shown us up in our study of industry secret documents, which were forced to be released as part of the 1998 Master Settlement Agreement following a class action brought against the tobacco industry in the US across 50 states. These were people who, through the states, filed claims of billions of dollars in damages to their health from smoking cigarettes and using smokeless tobacco. Delving into this industry document was a pivotal moment in my career during my postdoctoral fellowship. This work uncovered strategies designed to maximize profits while undermining public health efforts, using various tactics as listed in this Philip Morris International Corporate Strategy document, right in the middle there. Others are outlined in the Wheel of Corporate playbook depicted in the slide, as you see up. Most of the health-harming industry, like alcohol, beverages, and processed food industry, use the same playbook. They learn it from the tobacco industry. One of the early studies was to confirm that there were varying levels of nicotine in snuff, but the amount released and delivered to your body and across to the brain is based on the pH of the mixture, as carefully designed by the manufacturer. This key design feature of controlling the pH was found in secret documents to have been intentionally done to provide young and novice users the possibility of graduating from a low nicotine delivery to a high delivery nicotine product, which would have otherwise been unpalatable to a nicotine-naive user. In another study, we demonstrated that the industry intentionally designed snuff products for those who smoke, knowing that they would not necessarily make them give up smoking. In particular, as illustrated in the quotes, they designed this to augment cigarette use. I'll quote one of the secret documents of industry. It says, there is need to clearly position the product as a situational substitute for cigarettes, rather than a replacement. A substitute rather than a replacement. For those who have been following the debate in South Africa, for some of us, this is déjà vu. We saw this already 20 years ago. In particular, they want to offset regulatory strategies, such as banning on smoking in public spaces. Despite this knowledge to the industry, they still promote this product as harm reduction products for smokers around the world, including in South Africa. In collaboration with world experts, we published the first cross-country product analysis showing higher cancer-causing agents, TSNAs, in the same category of products supplied to low and middle-income countries like South Africa as compared to those they manufacture in their home, like Sweden. This study demonstrated that South African traditional homemade snuff that was tested had the highest cancer-causing agent of all snuff tested. But importantly, you can see the snus from Sweden. It's got about 602, while the snus they brought to South Africa was 2,700 in TSNAs. So when they say it doesn't cause cancer in our country, you have to understand that they may not be talking about the same product when they bring it to Africa. Knowing this did not stop the industry from using South Africa as a playground for the failed attempt to market snuff. Of course, they knew I was walking around collecting all the snus in the shops. I remember getting to Spar one day, and I was told I can no more buy. Somebody told them that they should be careful of the guy that is buying them, because I was buying them in bulk, and I was sending to US for testing. I'm sure they will still remember me in Spar in the Willows. It is pertinent to note the industry tried to ask the South African Parliament as early as 2005 to exclude the snus from the law on the basis that it is not a tobacco product. Again, for those who are involved with legislation now, you know this is not new to some of us. And that is a reduced harm. It's not a tobacco product because our products, or our legislation then, defined tobacco product as something that you suck or you sniff. And they said, this you don't suck it, you don't sniff it, you just place it in your mouth. Therefore, it's not a tobacco product. Needless to say, they lost the case. One of my earlier studies was to confirm also the varying levels, the varying levels of toxins in products outside of South Africa compared to South Africa was not only in the smokeless tobacco. This study was published last year. I'm sure you probably know IQOS or the heated tobacco. Again, confirming that the IQOS that comes to South Africa has much higher levels of cancer-causing agents than the IQOS that you find in UK and Poland. So these studies, together with others, demonstrates why we should be regulating tobacco products and not believe the industry. In continuing our research, again, for those who probably might have known, we also started collecting snuff or smokeless tobacco around Africa. I eventually collected about 26 of those products across 5 countries, buying them at different times on the shelf to see the differences. And of course, we found that N2 had the highest cancer-causing agent. We, however, also observed the levels of these cancer-causing agents varied across the stores where they were purchased, possibly because of the different times they've spent on the shelf. In Sweden, by the way, these products are kept in the fridge. But the same Swedish match that came to South Africa did not keep them in the fridge. These findings further highlight the need to regulate the use and the manufacturing of these tobacco products in the interest of public health. And then also decided to use what the US Environmental Protection Agency uses to assess toxicological agents and applied it for the first time to smokeless tobacco. This is what you do when you're bored in a winter city like Boston, thinking of just only crazy things. Because I remember people thought I was crazy when I said I was going to calculate every chemical lifetime cancer risk and determine the lifetime cancer risk for smokeless tobacco and compare it to other products. And voila, it was accepted, because it's always good to do something nobody else has done. It's easy to publish. What the study shows that the toxins in Swedish and US smokeless tobacco compared to the medicinal nicotine replacement therapy, and I think this is very important because I've heard tobacco industry say some of their products with low TSNA is as good as nicotine replacement therapy. Is not true. Because we demonstrated this already as far back as 2010. So usually the EPA uses 1 in a 1 million chance that you can get cancer in your lifetime of 70 years. Once you have a chance of getting cancer that is less than 1 in a million chance, the rule is that you have to have a label, a warning label. And only the nicotine replacement therapy that did not have 1 in a 1 million chance, the rest were 1 in 100,000 or 1 in, mostly 1 in 100,000. So this series of work informed the WHO's tobacco regulation study group to recommend to members to set upper limits to key toxicants in smokeless tobacco products. Now, the understanding of the deceptive practices related to targeting new populations of smokeless tobacco users, that is the smokers, and the understanding of the health risk led to the international call for action. In 2 different book chapters that are published, and 1 Seminar Lancet Oncology publication. In this paper, we report the outcome of analysis of global state of policy implementation to address smokeless tobacco, and concluded that there was an urgent need to extend the provision of the WHO FCTC to all tobacco products. Given all the work that I had done over the years, it was no surprise that the International Agency for Research on Cancer invited me to join a group of world experts to co-author the first handbook on oral cancer prevention. In particular, I led one of the working groups of the HIAC team of experts to review the level of evidence on the effectiveness of interventions designed to help youth and adults to stop smoking and using oral tobacco. The key findings from our group and others were published in this paper in the New England Journal of Medicine. The outcomes were not just that there was sufficient evidence that tobacco smoking and alcohol consumption are significant risks for oral cancer, but that behavioral interventions like brief counseling help adults to quit smokeless tobacco use. Just to recall it, that smoking obviously then became another focus of my work. As part of my PhD research, I'd already explored the links between adolescent smoking and smokeless tobacco use and oral health and mental health. Particularly, I was one of the first to look at the concept of sense of coherence, sense of coherence among adolescents, which is your worldview of stressors, and also looked at depression in relation to oral health, which suggests that what happens in the mouth is often a window into the overall health. As you can see from that graph, this was a longitudinal study that followed up children in Limpopo over an 18-month period, and we also examined the oral cavity to look at how clean the mouth was. And we found that those who smoked had progressive bleeding, and why those who didn't smoke did not have progressive bleeding. Progressive bleeding is a sign of gum disease. The second paper there was my late MPH student, Dr. Rantau. May her soul rest in peace. She showed for the first time in South Africa that the majority of adolescents who use snuff also smoke. That was about the time the tobacco company were actively pushing their Swedish-type smokeless tobacco as a harm reduction strategy. Again, that was 2012. So all of these things you see today all happened 10, 15 years ago. However, as soon as I realized that clinical research was not enough, there needs to be a better surveillance, structured interventions, and stronger policies. The WHO then provided this type of framework for surveillance or monitoring, implementation, structured interventions, and policies. And in particular, it provided guidance in Article 5.3 on how to prevent tobacco industry interference in the policy process. An obligation to all of government that are parties to the convention. And when I say all of government, it's not the Department of Health, but trade and industry, finance is the obligation to actually follow those guidelines. The provision of the FCTC is summarized in the acronym EMPOWER, which has also provided the framework for our research in recent years. M stands for monitoring, P for protecting the population from passive smoking or secondhand smoke. The O is for offering help to those who want to quit. The W for warning about the dangers of tobacco. E for enforcing bans on adverts. And R for raising taxes. Several publications on epidemiological surveillance to monitor pattern of tobacco use and smokers' tobacco use behavior were carried out in South Africa, extending often to low and middle-income countries and US. These are often policy relevant and used to support regulation, including the US. I was quite surprised when I saw one of my papers cited in the FDA disposition. It was quite rewarding. The latest of our papers, in fact, before I go ahead, one of the papers, as you can see up there, on water pipe smoking, was by my M student at that stage, the young Professor Flavia. I believe she's here. She's still young, but she was very young. It's always rewarding to actually find your students, in different spaces. Like the other M student at that time, she's now the Deputy Director General for African CDC. The latest of our analysis, in any case, showed the last 15 years that the prevalence of manufactured cigarettes have not significantly increased, despite the existence of high prevalence of illicit trade. What has increased is zoling, the use of roll your own, and the use of obli. And when you add that to manufactured cigarette, then you know that there's a significant increase in tobacco use. Then I also started looking at industry documents, one of the seminal study on impact of cigarettes on brand choice of South African smokers. This was informed by industry experiments on smokers. They do a lot of experiments of smokers, by the way. They found that smokers experience a different sensory experience from smoking the same cigarette when they pulled it out of a white pack as opposed to pulling out of a red pack. Same cigarette. And then the ones that smoked the white one said, this is very light, very nice. The ones that smoked out of a red pack said, this is very strong. But they didn't know they were smoking the same cigarettes. So the industry knew that the pack was a powerful message communication. So I looked for a way to replicate the same. So I wanted this on a population. So we worked and asked South Africans, What do you think about when you choose the brand of cigarette you smoke? I use the same sensory attributes. Is it the taste, the flavor, or how satisfying it is? Or the pack, what the pack looks like, what the cigarette looks like, the price, the perception that is risky, or, we did 3 sensory attributes and 3 non-sensory attributes. And then we structurally modeled that to find a pathway. And voila, the data obtained confirmed what the industry also did. That consideration for a brand pack that is based on appearance was directly related to their sensory experience of flavor, satisfaction, and the taste. These early studies provided fundamental evidence why packs needs to be standardized, because it does communicate expectation of satisfaction. We then went ahead and brave enough, Professor Flavia, then doctor, decided to do a PhD. And I said, the only thing I can make her, to keep her busy, is to give her a difficult job like this. She was really good at it, to my surprise, I must say. Put together 10 mock packs. So we tried to create our own packs. I remember because I asked, why were you creating this? So we were afraid of copyright. So we could have stamped these pictures on Peter Stuyvesant, but we had to create new boxes of cigarette packs. At that time, Australia was already, I think Australia has introduced the plain packs, but they were in court and being challenged by industry. To cut the long story short, this experiment showed that giving pictorial warnings to smokers increased their confidence to want or ability to be able to quit. I must say the top performing packs were those depicting lung cancer, leg gangrene, male impotence. I didn't know South Africans did not want to have that. There was also a strong effect on unborn babies. And of course, again, actually to my surprise, and it has now been consistent, the packs that display the effect on oral health have been very effective. Similarly, more recently, because we are also talking about new legislation, not our group, another group just last year in the UK, also showed that if you make the e-liquid into standardized pack, young people were less likely to be interested in it. But older smokers were not dissuaded from using it. So industry has no reason for why even e-liquids cannot be in standard pack. By the way, Kenya yesterday published their regulation for graphic warning on e-liquids that is used for vaping. South African smokers, as our study has shown, majority of South African population support regulation of e-cigarettes just the way cigarettes are regulated. This study of South Africans in 2017 also showed that 1 out of every South African is exposed in one form or the other to advertisement of vapes. The highest being among 16 to 19-year-olds, the teenagers. Having understood some of these interventions and policies were effective, we built a model on the rest of interventions, and based on providing advice in the clinical setting, banning smoking in public places, and particularly in the workplace, and increasing the cost of cigarettes, all increase the efficacy for a smoker to quit, make intention to quit, and eventually make the quit attempt and quit. So I became most interested in intervention for smoking cessation after getting a training from the Royal College of Nursing, thanks to Jennifer Percival, who provided this training over time that I started disseminating. We then had a series of publications on smoking cessation, in particular, this first randomized trial of TB patients to receive a brief intervention was done by our team. I was particularly interested in TB patients because 1 out of 10 deaths from smoking is as a result of TB. I trained a PhD student at that stage. I don't know if Professor Luvagi might be online. She did such a great job designing the study, now well referenced as the first and one of the few existing such studies that have established the efficacy of brief motivational intervention in helping TB patients quit and stay quit for up to 6 months. We were able to demonstrate 20% quit rate compared to 9% in the control group that received just brief intervention, a brief advice. It means even the brief advice is quite effective, even if you do not go through the detailed motivational intervention. The team also took interest in publishing studies of our findings related to smoking cessation outcomes in other settings like hospitals in Nigeria, dental settings in the US, and cancer treatment settings in low and middle-income countries. With funding and collaboration, the Mayo Clinic, with collaboration with Mayo Clinic in the US and Global Bridges, we were able to train about 600 health professionals across 10 countries in Africa. We introduced the first module for smoking cessation training in oral hygiene program at GP as well. In that picture, you also see the very young Professor Flavia right to the left. These were the first set of trainees. You remember Kidiboni from Denosa there. Joyce Jakavula, thank you. Where's Joyce? I saw Joyce. Yes. Remember those years? And that was the front building of dentistry. And of course, that's late Dr. Rantau. So we now move that knowing all of we know about the industry, we now know social determinants is not enough. There is, between social determinants and health outcomes, are those commercial activities of tobacco industry. In fact, in 2019, the Global Disease Burden reports that 4 commercial products, tobacco, alcohol, ultra-processed food, and fossil fuels, account for about a third, or 19 million deaths, of these 56 total deaths, or 45% of 42 million deaths from NCDs. So most deaths around the world are now from NCDs. 1.2 million of these deaths were linked to commercial practices of the commercial industry or the corporates. Despite these statistics, the multinational corporations continue to put themselves out as the solution to the problem they have caused in the first place. Our analysis of survey of over 17,000 school personnel across 29 countries showed that personnel who believed that tobacco industry should be allowed to sponsor schools' events were significantly less likely to support complete bans of tobacco advertisement and comprehensive smoke-free laws. So industry know why they sponsor the school events. It is actually always, I think that's how we titled it, that it threatens tobacco control. By the way, this is not only for tobacco. Industry-funded research is usually used to oppose regulations. As you can see during the debate on sugar levy, wherein the Institute for Race Relations, yes, the Institute for Race Relations, using industry-funded research, contends that sugar tax would not have any impact. However, contrary to that, as you see on the right, studies after sugar tax was announced and implemented show significant reduction of purchase of sugar beverages per capita, as can be seen on the projection on the right. Importantly, the purchase reduction was more pronounced amongst poorer people. Therefore, we know that this type of policies promote equity and health So we were interested in taxes because we also know there's increasing price of tobacco products or cigarettes would promote quitting and equity. However, very few countries, I think there's only one, Mauritius, that has reached the mark of 75% of retail price being an excise tax. So I was quite interested in the broader system. This is not yet been published, so you'll probably be one of the first that have seen this, to look at these issues of state fragility. Many a times, the industry, they actually go to fragile states that have very weak environment. So there's state fragility scores. I try to see if there's any relationship between state fragility score and what we call tax scores. That is how effective your tax structure is. And voila, very strong negative relationship. The more fragile the state, the lower your tax effect. We then looked at the component of state fragility, particularly what we call the social external intervention. That is, whether you are now requiring external economic aid or external security support. That was positively correlated with inequality. Countries that receive more external aids had their poorer people smoking more than the richer ones. Indeed, this was consistent with the studies that have shown that foreign aids actually worsens inequality. Conceivably, the commercial actors who become much stronger in those situations have economic and political powers to circumvent any equity-promoting interventions like increasing taxes. That study, consistent with commercial determinants of health frameworks, have shown us that we must look beyond corporate sectors or specific corporate sectors, but consider much broader systems, practices, and pathways which influence health and social inequalities. This includes acknowledging the ecosystem that supports and promotes the activities of industries and political systems which prioritize wealth over health. These systems may work differently in high-income countries as compared to low-income countries, and hence the need to also decolonize and contextualize these original frameworks. And this is the reason why I was interested in the state fragility, because most African states are fragile. So I will be working to improve the current model to include state fragility in the model. Nevertheless, these models has also helped us to focus more on the appalling broader global application, or applying the broader global application, and the fact that reminds us that it's not all industries that are negative. There are some that are actually helpful to health and equity. With the growing need for more systems approach to studying social determinants of health, among others, I decided to establish the African Center for Tobacco Industry Monitoring and Policy Research at UP. This entity originally started a few years ago just as an observatory in monitoring tobacco industry active interference while I was at SMU, Safaku Mahatou Health Sciences University. We have since been actively involved in production of biannual global index on tobacco monitoring and supporting writing of African regional reports. As you can see, one of the reports, South Africa is not doing very well. It scored 69. South Africa sits right to the right. So the more right you are, it means the more influence industry has on your policy. So South Africa, the last report in 2023, scored 69 out of 100, which regards to the extent of industry interference when we use the 7 indices. ATIM has also since developed a first mobile app for monitoring industry activities across the African region. and the first online training course for advocates and government officials in the region. We've also trained in person about 250 advocates and government officials across 12 countries in the region. We also have provided scholarship to master's degree students. 4 of them have graduated from SMU and have another 4, and I think some of them are in the room. Some postdocs and doctoral students might be in the room or online. In the true spirit of transdisciplinary research and conducting research with impact, the ATIM recently worked with civil society organizations on the Protect Our Necks campaign in designing its research priorities and disseminating its research findings. Through this engagement, we identified the need to provide local evidence on the pattern of e-cigarettes or vapes, and in collaboration with colleagues at the SAMRC, I've since published some papers, well, the first set of papers in South Africa that have been used with existing evidence to support the current bill before the Parliament. Of course, this bill continues to be challenged by the tobacco industry, particularly on the discursive argument of harm reduction. So what is this harm reduction? If we look at this map, it tells you the world all over has started having reduced smoking or reduced tobacco use. And I think that is very harmful to the tobacco industry, to their profit. And that is the harm reduction that they're talking about. But they want us to believe it's harm reduction not for people to die. But I then ask the question, it's very easy. Why don't you stop manufacturing the cigarettes? Why do you want to replace with something else? So indeed, the reality, in particular in African region, as you can see, we have the lowest tobacco use rate and experience the biggest decline since 2000. Maybe they can make a case for Central Europe or EU. They cannot make a case further where we already have smoking prevalence less than 5%, and daily use less than 10%, and daily use even 5%. However, South Africa is very different from the rest of African countries. Unfortunately, South Africa has the highest rate of smoking currently, daily smoking. And that's obviously, you can see the interference of industry, and that's what we need to crawl back. They often use the UK as an example of what South Africa should do. And I say to them, why don't you use Uganda? Why don't you use Gambia? Why don't you use Kenya? And you can see, or even use Brazil, after all, we are BRICS brothers. This is UK, 37 to 15%. South Africa has remained flat, but when you look at Uganda, from the same point of South Africa, and it's gone now to 8% without e-cigarettes. So I argue there are enough countries in the continent we can look at. The same thing for Brazil. Brazil would be your blue there. The same, about 25% 20 years ago, they've come down to 12%, but the industry choose to use New Zealand. I'm sure you all know where New Zealand is. New Zealand to compare to South Africa, Sweden and South Africa, I never get that. Because the story does not gel when they use African countries. Now, this is what they call harm reduction. So what we do, because when we say tobacco industry monitoring, it's important to let people understand. We monitor financials, marketing, and political. This is why it's a transdisciplinary research that we follow, because we use economics and we use market experts. When you monitor, you then find these are sponsored events. This is not anywhere else. This is South Africa. This is Woestand's Cotton First Festival, which happened in Johannesburg. And of course, they're very happy to post this on social media. So this, in front of views, selling Peter Stuyvesant. And they call this harm reduction. That is live stream. during COVID, they still had to launch this on live stream with flavors. And what do you get after that? Because we also monitor sales, every product that is scanned, we are able to monitor the sales. So what do you get? Of course, you see the drop in cigarette sales during COVID. It picked up right after it was released, and of course, it's gone flat, but it did not reach pre-COVID. But look at price. Even taxes were increased, prices went down. So the industry know how to absorb the prices in order to keep sales going. Only because South African government only increases taxes by just too little. So it's enough for them to be able to reverse that. But when you look at e-cigarette, look at that steep. Phenomenal increase corresponding to the time when they launched VUS. This is the beauty of doing this type of collective monitoring. They cannot say anything else. VUS is responsible for the big sales that we're getting in South Africa. And it keeps going up, and they keep making money. They stopped increasing prices recently. I think this was when the SARS started discussing introducing taxes. By the way, we produced the first paper, recommended the taxes, and they tried everything to discredit, and they failed. They wrote to the editor of the journal, they wrote to the ethics committee. Funny and luckily enough, we always made sure that we had all our ethics in a row. That was the work of a PhD student. There's a big concern that these e-cigarettes can be used to also smoke any other psychoactive substance like cannabis. So this is the reason why youths need to be protected. And I really hope South African government takes this seriously. We have a big crisis looming. Believe me, I have seen this before, and I can tell you this is really coming. Further evidence that this is non-harm reduction. This is GIS. We also use geospatial analysis. In this paper we published also in 2003, I just translated the geolocations to put where the vape shops are and where higher education institutions are located. There's a higher density around where young people are, higher education institution. We also then looked at density and the risk or the odds of you being an e-cigarette smoker. And voila, the more density or the more vape shops you have, the higher the risk you're going to be e-cigarette smoker, user. And also the closer you are to a vape shop. And you can see what those vape shop looks like. No wonder that those vape shops are associated with an increased risk of using vape. This provides evidence that we need to also regulate vape shops. What is important to notice here, Kailecha and Mitchell's Plain, there are no vape shops, but there are a lot of smokers. If they're really serious about addressing equity and tobacco use, this is where we should have been finding vape shops, not observatories and constantia. So again, we have provided evidence for the state to understand that this is not about harm reduction. So these products, why are these products attractive? They're attractive to the industry because of the projected phenomenal increase in 15 to 24-year-olds in Africa. You can see that line compared to other parts of the world. It's only in Africa that you will have that market. And they will not let go, except we actually stand our grounds. They also want to have access to decision makers, by the way. They want to have access to the media and to health professionals. And that is the reason why harm reduction is their entry point. In South Africa, the tobacco industry has been invited to present to their harm reduction argument to lower tax to the Finance Select Committee of Parliament. And they actually got away with it, getting only 75% of, for a tobacco product like heated tobacco product, only 75% of cigarette tax. Philip Morris International funded consultants have also delivered CPD lectures to health professionals using Health Professions Council accreditation numbers. It is a national example of how the so-called harm reduction products have opened doors to decision makers that were closed before. But the problem is not just in South Africa. As I draw closer to the end of my talk, I have to touch the issue of the harm reduction to debunk the assumptions using science. The assumptions for harm reduction is that these products are literally safe and that everybody that is aware of the risk of smoking would just simply move to them. We all know that's not true. The large number of people who are hardened smokers and are unwilling to smoke, to give up smoking, would take up this and it will help them give up smoking. Thirdly, that there are no other options to help people stop smoking. We already demonstrated that motivational counseling works. And lastly, that there will be no unintended consequence of introducing this into the society. And we are worried about youth initiation and dual use. Dual use means you continue to smoke and you add additional toxins to your body. I'm going to deal mainly with the last one, but before then, I think it's important to note low toxicity or low toxic exposure is not the same as low harm. Exposure is different from harm. The body and the biology is very different. Low toxic disease, for example, this study has shown even one cigarette can give you 50% of the risk of the full pack. Smoking one cigarette a day can give you 50% of the risk of coronary heart disease of the full pack. So we do not have a linear relationship to say, because basically what we have with harm reduction is that people are jumping down from 30 floors from smoking, and they are telling them to go and jump from the 10th floor. Well, I'm not sure whether they will still survive it. Our study looking at 18,000 South Africans also showed that e-cigarette in South Africa, at least as is used in South Africa, actually reduced long-term quitting. It reduces quit intention, increases smoking relapse, and increases nicotine dependence. I know they don't like this. Again, they fought to make sure that this paper does not get published or cited, but unfortunately, it is cited in the best of journals that you can get in tobacco control, the BMJ. We also looked at the population level, young people, 16 to 34. Again, we do not see any evidence of harm reduction. Smoking is going up, e-cigarette use is going up. So there's no harm reduction in South Africa. Again, to remind us, the impact of a product on public health is not only on the toxicity, but how many people are exposed to this low toxicity as compared to highly toxic substance that only few people are exposed to. Harm reduction comes from illicit drugs, a very legitimate strategy to help those who are not able to get off drugs. For example, the opioid substitution therapy. However, this is supervised, so we call it high-risk strategy. There's danger in using it as a population-level strategy, and this is the danger. Those who might need, or the smokers or hardened smokers, they're actually spread around the whole population. So if you want to expose them to this product, you're exposing everybody, including the youth. And of course, what do you get is all these unintended consequences that have been shown in several studies. Initiation of e-cigarette use. The UCT group have shown very high e-cigarette among high school kids. Dual use, marketing, relapse, and of course, shifting the social norms. So what's the future direction for commercial determinants, given all the lessons that we have learned over the years? One is that the commercial determinant framework should be further developed or adapted for local context, particularly as I've shown, the state fragility, and how that influences the power that the commercial actors get. We need to promote transdisciplinary approach to training public health workforce and highlighting the importance of commercial determinants of health. More importantly, though, we need to also protect the safety and credibility of researchers because they are often under attack by the tobacco industry. And we published this public health playbook also 2 years ago that helps the public health workforce to be able to protect themselves. We need to be united in their approach to governance in engaging harmful commercial actors. Because the problem we have the Article 5.3 guideline in the Framework Convention on Tobacco Control, but you then have alcohol industry and food industry doing the opposite. So there's need for a united governance and for government also adapt the Article 5.3 guidelines for these other commercial actors. We need to extend the concept of harm to consider inequity that these actors cause in different communities, that is population harm. And finally, we need to develop different engagement approaches for a range of community and stakeholders in the discussion and decision about commercial determinants, particularly in an environment like ours, where you have a high unemployment rate, and particularly among young people. Sometimes it's very difficult to speak to them about not accepting sponsorship or CSR. However, the social media space is a space that public health practitioners could also begin to use in reaching this particular population. As I close, there are a few directions for us and commercial determinants as a field. Transdisciplinary research that is community-oriented and equity-focused. We need to look at the intersectionality framework and human rights approaches in the context of commercial determinants. Strengthening implementation of WHO FCTC, which is SDG 3.8, needs better global governance for tobacco control and including improved diplomacy at African CDC, World Bank, and the World Trade Organization, particularly given the impending African Union's Africa Free Trade Agreement that industry may exploit. We need to consider tax shifting. We have demonstrated the possibility to use brief intervention, even without pharmacotherapy. And we demonstrated that this actually, I did not mention that all of those interventions were delivered by lay health workers, community healthcare workers. Because I know the government has been struggling to understand the importance of community healthcare workers. They can be trained to deliver life-saving intervention like smoking cessation, prioritizing priority population of people living with HIV or people undergoing TB. TB treatment, given the large number of deaths that you find among TB patients who continue to smoke. We need to create avenues to scale this intervention using technology. We now have AI and, of course, mHealth that can help us do this. As I conclude, we need to begin to think globally as we act local. But before I go off the stage, I need to thank a number of institutions and funders that have supported my career all these years. Special thanks to the African Capacity Building Foundation and the Bill and Melinda Gates Foundation that has been providing support to our work in the last 7 years. And of course, the Medical Research Council, NRF. I hope I don't miss any funder. It's not in the quantity, but the fact that you have been able to support us. Of course, a lot of institutions, the WHO, University of Benin, the Department of Health in Limpopo, because if they didn't allow me to do my studies, I wouldn't be here today. The Gauteng Department of Health, and I'm still saying, please do allow people to do the studies. It does make them become people that would be agents of change, even for the province itself. Of course, this cannot happen without the support of my family, my wife and 2 boys. Thanks for all the support and for putting up with my absence. It is with mixed emotions that I celebrate this day with all the students and postdocs and doctoral students and collaborators in academia, in civil society. As you can see some of the pictures there. That was the Conference of Party. Sometimes as pure academic, you never understand what it takes to negotiate policy until you sit in those rooms and spend 3 hours trying to change a word. And every country raises their flag. Unfortunately, once a country does not agree, even if you have 193, you can't move forward. It is very frustrating. But thank you for all the resilience. And of course, like I said, it's with mixed emotions. It's because I miss my project manager, who should have been here. He was my last PhD student graduate, completed his PhD last year, and unfortunately passed away in December. Osius Dewa, thank you for all you did. And indeed, this is also dedicated to you. I also like to acknowledge support from late Martin Rowe. This was in New Zealand. He also passed away late last year. He was the mentor for all the smoking cessation work I did, and of course, getting me to London for the training. Finally, I look forward to future collaboration with Africa CDC. Like I said, Claudia Shilomania has been a good collaborator, sitting now at Africa CDC. And I was able to have good discussion with the DG and ready to support the commercial determinants of health, which they have accepted as a strategy to controlling NCDs. To everyone, and of course, as you can see, we have been able to defeat the tobacco industry. For those who know, the Marlboro man was always riding the horse. The horses dropped. It wasn't my fault. It was the fault of the Marlboro man. Choked the horse with smoke. And now we have risen from unsuspected spaces, and we are riding on. Thank you very much for listening.
Ladies and gentlemen, this occasion marks not only a celebration of outstanding contributions to academia, but also a reaffirmation of Professor Ayo-Yusuf's commitment to improving public health policies and outcomes. Let's give him another hand of applause. Professor Ayo-Yusuf's address shedded light on one of the most pressing public health challenges of our times. Tobacco use remains a leading cause of preventable death, and despite global efforts, sub-Saharan Africa continues to face an expanding epidemic driven by aggressive industry tactics and systematic vulnerabilities. His work critically examines how the tobacco industry and other health-harming sectors influence policy and public perception, often at the expense of community health well-being. Through groundbreaking research, policy influence, and international collaboration, Professor Ayo-Yusuf has been instrumental in strengthening evidence-based interventions to counter industry interference. His commitment to transdisciplinary research and community engagements underscore the importance of translating knowledge into impactful action. Today, he challenges us to envision a future where strategic research and policy advocacy drive us towards a tobacco-free sub-Saharan Africa. Colleagues, let's continue to contribute and to do research that makes a difference locally and globally. Finally, allow me to thank Professor Loretta Ferris for leading us in today's inaugural address. Members of the University of Pretoria Executive for continued support, the Executive of the Faculty of Health Sciences, and the team, specifically Samantha and Karen, thank you for making this event possible. Distinguished guests, staff, students, thank you for joining us this evening, whether online or in person. Please join us for refreshments. Stay safe and good night. May I ask you to please stand while the procession is leaving the room.